Hi friends, I am Dr. B.B. Rao of Usha Clinic and founder of the websites viewmedicaldoubts.blogspot.com and raghavamedicaldoubts.com. Through these videos, I am providing the basic knowledge about the commonly occurring diseases, treatment and surgery details when necessary for the medical knowledge to general people and for reference to medicals. Today I am going to discuss about the anesthesia during obstetric procedures. The childbirth is a strenuous process and every mother likes to skip the process at that moment. So different methods were adopted for relieving the pain of labor. Analgesia. The question of analgesia is on a different footing. The analgesia should relieve the patient of actual suffering, will not anyway affect the course of labor or the prognosis of the fetus. The safe analgesic is one that will satisfy the following conditions. It should completely relieve the pain during labor. It should not interfere with progress of labor, force of uterine contractions or their frequency. Should not increase the necessity for artificial assistance during delivery. The child should be born alive without any degree of asphyxia. There should be no increased risk of postpartum hemorrhage. If the above conditions are fulfilled, one would advocate the use of analgesic in every case, and the labor rooms would be more pleasant and comfortable for the patients, the attendant, midwives and obstetrician. Regarding analgesics in obstetrics discussed in previous page. Regarding anesthesia, various types of anesthesia are employed in obstetric operations depending upon the nature of operation and complications, if any, in the mother. The common types employed are intravenous anesthesia, inhalation anesthesia, regional anesthesia and local anesthesia. Inhalation anesthesia. Before administration of any inhalation anesthetic to the mother for delivery, the following particulars should be remembered. Stomach must be empty to prevent the vomiting during anesthesia and aspiration of vomit into the respiratory tract. During delivery, there is a delay in emptying of stomach, and even after 6 hours, stomach contents may be retained. If anesthesia is to be administered when the stomach is full, the stomach must be emptied by introducing a stomach tube before inducing anesthesia. If the mother is exhausted due to prolonged labor and dehydration, an intravenous drip must be started, not only to correct the fluid and electrolyte loss, but also for quick IV medication whenever necessary. Deep anesthesia with volatile anesthetic agents may cause fetal depression, uterine inertia in postpartum hemorrhage. Anesthetic agents used in obstetrics: inhalation drugs, nitrous oxide, ether, halothane, methoxyflurane and trichloroethylene are all can be used with or without muscle relaxants. Anesthesia with ether is to be used with caution. Inhalation anesthesia: thiopentone sodium. The entire quantity of this drug passes through the placental barrier quickly and hence fetal depression follows administration within 2 minutes. But after 7 minutes, the blood concentration falls to insignificant levels, so that the infant born after 7 minutes is safe for depression. About 200 milligrams may be given for induction of anesthesia or as a total anesthetic for delivery of the aftercoming head in breech extraction. Halothane. If concentration of halothane is not exceeded above 1% for maintenance, it does not produce atony of the uterus. Hepatic damage occurs only after repeated administration of this drug at short intervals. Proper halogen anesthesia is ideally suited for obstetrics. Muscle relaxants. Muscle relaxants of a non-depolarizing group like tuvocurarin, galamine cross the placental barrier, but those of a depolarizing group like suxamethonium do not pass through and hence safe for the infant. General anesthesia for cesarean section. Pre-medication consists of 0.6 milligrams of atropine IM on 1 hour before anesthesia. Choice of technique of anesthesia depends upon the skill of the anesthetist. Any of the following techniques may be adopted. Method 1. After induction of anesthesia with ethyl chloride, inhalation anesthesia may be maintained with either by the open drop method. Maintenance of good airway is essential. Method 2. After induction of anesthesia by intravenous sleep dose of thiopentone, anesthesia is maintained with nitrous oxide and oxygen with either triolene or halithone. Method 3. After induction of anesthesia by intravenous, small dose of thiopentone 150 milligrams to 200 milligrams with 50 milligrams of scoline. The patient is intubated and anesthesia maintained with nitrous oxide and oxygen with either or halogen. The respiration of the mother should be supported till spontaneous respiration is satisfactory. Method 4. After induction of anesthesia with 150 milligrams to 200 milligrams of thiopentone, the patient is intubated and anesthesia is maintained with nitrous oxide and oxygen till the baby is delivered. Then a muscle relaxant like galamine 80 milligrams or tuvocurarin 15 milligrams with pethidine 50 milligrams is given intravenously and anesthesia maintained with nitrous oxide and oxygen under controlled respiration. This procedure is indicated when the fetus is premature, fetal heart is precarious, there is a history of stillbirth, mother is in a severe shock, mother is suffering from metabolic diseases and toxemia, and previous history of repeated postpartum hemorrhages. Regional anesthesia in obstetrics. Spinal analgesia for cesarean section. Spinal analgesia is safe for cesarean section in experienced hands. Only small doses of hyperbaric solutions like Nupercaine 5 milligrams means 1 ml or Xylocaine 50 milligrams in 1 ml is to be injected in L3-L4 intervertebral space. Due to high pressure in the inferior vena cava, 160 milligrams of water, the rise of analgesia is higher in these patients. To prevent hypertension, vasopressors like ephedrine 45 milligrams must always be given IM and repeated IV if blood pressure falls. During the whole period of operation, the mother should be oxygenated with 100% oxygen and watched carefully for respiratory failure. Spinal analgesia for cesarean section is preferred to inhalation technique in presence of lung complications, uncomplicated diabetes mellitus, previous history of postpartum hemorrhage and hyperpyrexia in the mother. Contraindications: cardiac disease, obesity, hypertension, shock and toxemia. Extradural block. These may be given by lumbar root or sacral hiatus. When prolonged action is required, a catheter is introduced into the extradural space and Repetitive injections of 1% xylocaine made for continuous extradural technique. They are useful not only for analgesia in the second stage but also for conducting operative procedures for delivery, including cesarean section. Disadvantages: prolongation of duration of labor, marked increase in instrumental delivery, and difficulty of administration. Local anesthesia. It is used for both major obstetric surgery as cesarean section and for minor operations like repair of episiotomy and perineal tear and outlet forceps. It is the method of choice when the general conditions of the mother is poor due to cardiac failure, severe shock, or any serious illness. For cesarean section, using 0.5% lignocaine infiltration is done along the line of incision, the layer by layer, as the surgeon cuts through. After opening the perineum, 10 ml of 1% solution is injected into the broad ligament of both sides of uterus, and rest of the operation can be continued without any further infiltration. This anesthesia has bad effects on mother or fetus. This anesthesia has no bad effects on mother or fetus and does not require the services a trained anesthetist. Paracervical block. This consists of blocking the pelvic plexus in the broad ligament. Needles are introduced for a depth of about 1.5 centimeters into the broad ligament, approaching lateral to the cervix at 3 o'clock and 9 o'clock positions. About 10 ml of 1% lignocaine or 0.3 bovacaine is injected on each side. Pudendal block. There are two methods present: transperineal pudendal block, transvaginal pudendal block. Transperineal pudendal block. This technique consists in injecting freshly prepared 1% solution of procaine or novocaine in normal saline through a 6-inch 22 gauge needle inserted through the ischiorectal fossa to the ischial spine with a glued index finger in the rectum as guide. Injection is made slowly and aspiration made frequently as the needle advances. After 5 ml is deposited at the inferior surface of the spine, the needle is advanced till the tip is barely through the sacrospinal ligament where 5 ml is injected. The rectal finger is then withdrawn. The needle tip is withdrawn to just beneath the skin. It is then inserted to impinge on the medial surface of the ischial tuberosity where 5 to 8 ml is injected. The needle is once more withdrawn to just beneath the skin and the labia on the side infiltrated. The same procedure is carried out on the opposite side. Transvaginal pudendal block. The needle with its end protected by the ball of the index finger introduced into the vagina till the finger presses against the ischial spine. The finger is raised and the needle is advanced just posterior and medial to the tip of the spine. After raising a small submucosal wheel, a needle is advanced to the sacrospinous ligament, which is then infiltrated with 2 to 3 ml solution. The needle is then advanced a piece to pierce the ligament, and the remainder of the solution is injected after making sure by the aspiration of guard against intravascular injection. Though the presenting part is on the perineum, injection is possible between the contractions. Pudendal block seems close to the ideal second stage anesthetic. For most emotionally stable women, manual rotation, the use of outlet forceps and episiotomy are possible without appreciable discomfort. It has some disadvantages. The performance requires several minutes, and for difficult maneuvers, the relief from pain is inadequate, and the anesthesia may wear off before episiotomy repair is completed. As a routine pudendal block anesthesia alone is good for vaginal delivery, mid-cavity forceps, breech deliveries. It is advantageous to inject chlorpromazine 15 milligrams pethidine 100 milligrams in 20 ml of 5% glucose intravenously slowly prior to the pudendal block. This ensures good pre-medication, and the patients are in a somnolent state. After the delivery is over, they sleep peacefully for some hours. There will be no post-anesthetic vomiting, and the recovery is peaceful. Sometimes there may be a drop in blood pressure. Hypnosis. It also has been successfully used to allay pain in labor and is also useful in some selected cases of cesarean section. That's all about the anesthesia during obstetric manipulations. And in the next video, I'll discuss about some other disease. Thank you.